I want. Sure.
Hello, Dr. June.
You have a camera? You have the camera?
Hello, I have camera. How are you?
Good, good,
I'm fine.
good, good. You work a lot?
Damascus. You know Damas Rose? You see Damas Rose.
Your camera doesn't.
Wait, camera. No, no, there's no camera allowed. No camera allowed.
Okay, no camera.
No camera allowed. Only voice.
Okay. Can you hear me okay?
Okay.
You can hear
Re-enter.
me? You can hear me okay?
I hear you. I hear you.
Okay.
I hear you.
Okay.
You see me?
Yes.
I see you.
Yeah. Yeah. I can take you over the camera if you want.
No camera is
What the heck?
down. No camera. Only this hand and mute and mute only. Re-enter. Leave and re-enter, Dr. John. Make re-enter. As I leave now and re-enter.
Okay. So I plan this incision just depending on where I want to make the
There's Shaheen.
Hi,
How you doing today?
I'm fine.
Hey, listen, do you want to introduce the host? You're not hosting, right?
Yeah, today Dr. Abdurrahman told me to thank the doctor at the
Yeah.
end and
Oh.
start the questions.
Okay. Okay. Why don't you introduce the host? Okay. You know who the host is, right?
Yes.
Okay. Just say, can you put your background on the Neurosurgical TV and introduce the host? Introduce yourself. And just say that, I represent Neurosurgical TV, and I'd like to introduce the host. That's all you say. Okay?
Yeah, okay.
It'd be nice to have the background if you could.
Okay.
In other words, you're taking my place. Instead of me saying, hi, I'm John Bennett, Neurosurgical TV, you're going to say, I'm Shahid from Neurosurgical TV, okay?
Yeah, okay.
And I'll just tell you when to go. I'll say, go.
Doctor, can you send for me the background?
Oh, you don't have one?
Yeah.
Do you have one?
No.
Okay, let me see if I got one here. It's no big deal. I'll try to get it. Okay. Okay, put it in the chat. Oh shit, it's not working. It's not working. So you have a WhatsApp, right?
Yes, I have WhatsApp.
I'm connected to you on WhatsApp.
Yeah,
Let's
okay.
see. Uh, we'll have to figure it. I can't get it. Oh, no, I can't upload it. Okay, that's okay. Don't worry about
Yeah, okay.
it. Okay. Oh, Atabati. Okay, have you met Omar Shahid?
Yes?
Have you met Omar? Omar, say hi to Shahid. Omar's a neurosurgeon from Syria.
Oh, nice to meet you.
He's a dedicated Zoom advocate. Good day, Uday. Is your camera on, Uday? You can meet another neurosurgeon
Inshallah.
from India.
Yeah.
Are you there, Uday? Hey, there's Ata. Ata, how you doing?
Yeah, hi everyone.
You have a camera on?
I don't see that option.
Oh, you don't have a camera?
I have, but I don't see it from activated from your end.
Thanks for coming. Okay, has anybody been in contact with the speaker? Shahid, do you know if anyone's been in touch with the speaker?
I will ask Dr. Abdulrahman.
Yeah, ask someone
Yeah, okay.
because the head didn't come today. He's not coming. The hunger. So Ravi, how you doing, Isha?
Yeah, hi, I'm doing good. How are you doing, doctor?
Very good.
Mm.
Now, are you the host, Isha? The hostess? Who is
yeah,
the host? Who is the host?
Dr. Aisha is supposed to present, but I think she's unable to attend today, so I don't mind.
No, I don't know who you arranged the hosts. Who's going to be the host today?
I can be the host because I think both of the main panelists, Dr. Abdul Rahman and another doctor, they're not able to attend today.
Okay.
Yeah.
Yeah, please, that would help.
Yeah, sure. Since I'm doing this last minute, do you know how I should introduce Dr. Tao? I looked him up. I know that he's part of the North Bristol NHS Trust, and I know that he specializes in skull-based surgery and neuro-oncology.
Yeah,
So,
and where he's from. That's all.
okay.
And he's from London or UK.
Mm-hmm.
Okay, someone needs to get a hold of him to make sure he comes. This is not very
Yeah.
organized. Who is supposed to get a hold of Dr. Tao? Nobody. Okay, who's the head of the webcast? Who's taking over for Dr. Aliter? Like, in other words, who's running it?
Yeah, actually, both the doctors who are running it, I mean, I just got a message 5 minutes ago that they're not able to attend, so I'm also not sure what's going on. I'm just trying to get in touch with.
Okay, yeah, please try to
yeah.
get in touch with Dr.
Yeah.
Tao. Yeah. Hopefully social media, either WhatsApp or Facebook or.
Dr. Abdulrahman said 2 minutes and he will come there.
Okay, Dr. Tao?
Yes.
Oh, good. Okay. Okay, we'll start in a few minutes. Oh, here he is. Here's Mario. Okay, Shahid, I'll go 5, 4, 3, 2, 1, and then you start. Hi, Dr. Teal. Welcome.
Well, thank you. Thank you for the invitation.
Thanks for coming. This is Isha Ravi. She's are you a med student, Isha, or are you a resident?
No, I just graduated last year, so
Okay.
I'm hoping to apply next
You'll
year.
be introducing Dr. Teal,
Yeah.
and Shahid will be introducing you, Isha. Okay.
Osha,
Okay.
okay.
Okay, you ready to start?
Yeah, sure.
Okay, 10, 9, 8, 7, 6, 5, 4. Ready, Shahid? 3, 2, 1.
Hi, I'm Shahad Al Sinan from Bahrain from Neurosurgical TV. It's my pleasure to introduce our distinguished guest, Dr. Mario Tio, with my friend Isha.
Yeah, thank you, Dr. Shahed. Good evening, everyone. It's my pleasure to introduce Dr. Mario Tio. He's a consultant neurosurgeon at North Bristol NHS Trust. Dr. Tio specializes in skull base and complex neuro-oncological surgery, and he's widely recognized for his work in navigation-guided techniques, as well as simulation-based neurosurgical training. We're truly honored to have him with us today, and Dr. Tio, thank you for joining us, and the floor is yours.
Thank you for the invitation. So I'm gonna share my file.
Okay,
Does it work?
okay.
Yeah.
Let's see, where is it? Okay, thank you for the
Oh,
invitation.
excuse me, Dr. Teal, it's not full screen, not presentation mode yet.
Oh, I see. Okay.
Yeah, you can see the slide, right? It's not full
Yes.
screen.
Slideshow.
You see at the bottom, there's 4 icons at the bottom right. There should be an icon at the bottom right, not the top, the bottom.
Bottom right.
Yeah,
Here.
there's 4 icons. No,
Okay.
no,
No.
try it again.
Okay. Mm,
First, share the screen.
So do I go back to share?
Share the screen first.
Yep.
That's the first step.
Yep.
Share. Yeah,
Okay, share.
okay. There you go, perfect.
Okay. Thank you for the invitation. So I've been asked to talk about introduction slash innovation to clinical neurosurgery. Uh, I have I'm a consultant neurosurgeon in Bristol in the UK, and so I thought what I'll do is to take you through several things for the next 40, 50 minutes or so. I'm gonna start with like a little personal journey and then a bit of career insight into the life of a consultant neurosurgeon, what the future and the innovation look like, and some of the misconception about neurosurgery, and advice and tips for the career if you decided to pursue neurosurgical um, for your future. So I come from Malaysia, a small country in Asia, and did my sorry. So I did my medical school training in the UK, then went to the United States for my medical electives, as well as East Africa in Uganda, then went to South Africa to do trauma surgery in Cape Town, and did some further training in Europe, in the Netherlands, in Helsinki, um, and then went to do my fellowship training in Stanford in California, and then went back to Malaysia, back to the UK, and worked as a consultant neurosurgeon. So the journey is clearly not straightforward. Travel around the world to gather experience from various experts in neurosurgery in order to get the best to deliver best service for our patient, and that's the aim of what we need to do to have a successful career. And I think a lot of people here are all from all over the world, so don't be afraid to dream big and have big ambition. So when I come back to work in Bristol, this is a 75th anniversary that we celebrated a couple of years back. So you can see it's a department which is fairly influential. We think that it's among the best in the UK. And we have a lot of alumni that come from all over the world. So during that 75th anniversary, we have very old professors and some newer generation, and also some of our alumni that come back from the United States, from East Africa, from European countries, and also from Asia. So what is the achievement for Bristol Neurosurgery? We have several. We were set up by the first female neurosurgeon in the world. And in the 1940s, there are several UK and world firsts that come from here. So you can see that certainly we have quite a lot of achievement over the years. From clinical innovation point of view, we developed one of the first world neuroendoscopy, and also the cervical joint, which has now been incorporated into the prestige disc by I think it's by Medtronic. So we also done one of the first pioneering work for a nerve growth factor implantation for patients with Parkinson disease. Among the first in the world, and certainly the first in the UK, to incorporate neurosurgical robot in neurosurgery. So this was back in the 1990s. So we used robots still in our clinical practice. At the moment in our department, we have 5 neurosurgical robots. So where do the alumni come from? So we have a lot of delegates. You can see these are where the alumni are from, ranging from North America through to Asia, in Africa. So the influence of Bristol Neurosurgery has been pretty wide and far. What is the work like as a consultant neurosurgeon here in Bristol? Now, clearly day-to-day work, there's a lot of challenges. Some of the things that we are most we find most enjoyable about is the surgical work. So this is an example of an aneurysm that we deal with, a wide neck ACOM aneurysm with the clipping. You can cure the aneurysm. So nowadays, a lot of aneurysms are being treated with endovascular treatment. So clipping of aneurysm is still available, but in small numbers. What about the least rewarding part of our work? I have to say it will have to be the bureaucratic administrative work. We have to deal with a lot of this sort of bureaucracy, but I guess that's part of our work. Hopefully, the reward of seeing patients getting better is enough to keep us going in this very challenging field. The challenges that we face are multiple, including some of the uncertainty we see for the patients, even though we think that we might have done a good operation and the outcome might not be as ideal. So certainly we have to be strong enough. Some of the key skills and qualities we need to have as a neurosurgeon is to have the resilience to be able to carry things through, even if things do not progress to be the way we wanted it to be. So currently, for example, I have a case where the patient has had we thought a good operation for a vestibular schwannoma resection, but then it's been complicated with postoperative hematoma. So there has been challenges. Patient has got delayed hematoma, they bleed a day later. So even though it's not directly a consequence of the surgery itself, we have to be strong and be the energy, the hope for the family to continue for the patient journey. Here, I just put a little video clip up on certain. This is a robotic microscope that we have recently. It's a good technology. It's very similar to a microscope, but if anything, the robotic arm has special features where it can be controlled with voice command, and it will have a very good magnification and visualization that helps to improve our visualization of the optic field. So this video show you some of the characters of some of the exceptional features with this technology. So the vision you can see is all in front and is portrayed a bit like the airline industry, where as a pilot you have everything portrayed in front of you. So we have high magnification where the small vessel, a millimeter vessel, can be zoomed up to more powerful than currently the carnivore size microscope, and the magnification, the focus is also better than what we can see. So this is some technology that we are using for some of our cases. It's not suitable for all the cases, but some of our cases we're using it very successfully. So you can sit comfortably, and the positioning of the robotic arm will be voice control and also by a wand, like a little magic stick that you can use to guide the direction of your light source. Now, neurosurgery itself has subspecialized, so you can see here that there are multiple subspecialties. It's no longer the same, and there are different types of neurosurgery now. So there are the subspecialty cerebrovascular, where we're dealing with predominantly blood vessel in terms of either a blockage like a stroke or a bleed like a hemorrhagic hematoma. And the bleeding one can be due to some of the underlying disease process like aneurysms or AVMs or carcinomas. And then there are some people that specialize in skull-based surgery, which deal with predominantly benign tumors like meningiomas and schwannomas. There are the oncology subspecialty dealing with the glioblastoma, primary intrinsic brain tumors, functional and epilepsy dealing with movement disorders, pain, pediatric neurosurgery concentrating on children, spinal neurosurgery for the spine, hydrocephalus for the CSF hydrodynamics, and trauma. So these are the different subspecialty in neurosurgery. So it's no longer the same for everyone. So depending on your personal interest, so there are different innovation that's going through for the different subspecialties. So I'm gonna talk it through with you for some of them. So cerebrovascular, for example, like in Bristol here, we are a bypass center, brain bypass center for Moya for brain aneurysm. We also deal with brain AVMs, carcinomas, aneurysms, and we work very closely with our stroke and interventional colleagues to deliver the thrombectomy service. From a research point of view, we work on the vasospasm and also some of the nationally Health Institute funded research, including randomized controlled trial. So some of the recent trials we've completed recently, including the interleukin receptor antagonist study to look at vasospasm reduction after subarachnoid hemorrhage. Now, this is an example of a Moya disease. So Moya is a case whereby this is the normal configuration of internal carotid artery. You can see the trifurcation, anterior cerebral artery, middle cerebral artery, and posterior communicating to go to the posterior cerebral artery. So this is the normal configuration. For patients with Moya disease, you see that it doesn't have that anymore. So this is just a posterior circulation that goes to the back, but you lose the anterior cerebral and the middle cerebral. So instead, you get this sort of very friable Moya vessels. And in this case, patients are at risk of getting strokes and bleed. So what we do is we harvest one of the scalp artery and connect to the brain, and this is what we call the brain bypass using STA to MCA. To improve the brain perfusion, and this would normally help reduce the very friable vessels and disappeared over time. And that also reduced long-term stroke risk and bleed risk. And you can see this is what the graph looks like before and after. So now, instead of supplying the scalp, it goes into the brain. So this vessel has now maybe tripled in size. And from a 1 millimeter vessel, it's gone to 3 millimeters and supplying the middle cerebral artery. And that's because the underlying internal carotid artery has blocked off. And this is instead of the internal carotid artery is supplying the cerebral perfusion. Now we get our patients from different parts of the UK. Now other case would be for like complex aneurysm. This is a case of a fusiform dissecting MC aneurysm. So you can see the vessel is very irregular looking. Hopefully this video will play. It's a video where we have the aneurysm exposed and then we harvest the radial artery. And from the radial artery, we can bypass the disease segment and we instead put a graft from the neck into the brain. You can see this is the part of the harvesting of the radial artery. We map out the surface of the radial artery in order to make sure that it doesn't twist, because when the vessel twists, then the flow wouldn't work. Now, once we divided the radial artery, then we'll be able to remove it from the arm and then implant it into the neck. So now we have exposed the external carotid artery. So now we have marked out the lumen of the external carotid artery, and then we anastomose using this 8-0 suture, connecting the radial artery to the external carotid artery. So the suture is very thin. You can see once it's connected, then we'll check that the graft is flowing. So you can see there's pulsation of the graft. So now the graft is now flowing into the brain. And this is a form of a brain bypass that we do here. So on the angio later on, you can see that the aneurysm has disappeared, and instead the graft is providing the blood supply to that particular branch. And this is the CT angiogram that we can see from the external going into the brain. We work closely with our colleague because the stroke thrombectomy service is well established. And some of you might be familiar with the stroke randomized controlled trial that showed that if you can reperfuse the brain before the infarction occurred completely, then you could, with very high chance, reverse the patient's neurological deficit. So now we provide 24/7 stroke thrombectomy service here in Bristol. So that's part of the neurovascular service. You can see giant aneurysms is another one. Some cases can be coiled off, as shown in this case very successfully. There are also some examples where aneurysms need to be diverted with either stents or other type of saccular devices. Now, just move on to neuro-oncology. What about neuro-oncology? This is an intrinsic brain tumor. So when you take out intrinsic brain tumors, we incorporated technology where we can do all this fiber mapping. You can map out the arcuate fasciculars, the cortical spinal tract, the optic radiation, even though you don't see that on the brain. But once you have mapped this out, then we have like a 3D goggles. You can sort of do a 3D modeling of how this tumor is in relation to the fibers. And when you're resecting these tumors, how far away are you from these important fiber tracts? And that will give you more confidence in resecting this sort of tumors. So this is another example where we, on the surface, we don't see all the fiber tracts, but then this tumor is in the insula. So you can see that in the insular dominant hemisphere, we want to make sure we are avoiding all the important fibers, the arcuate fasciculars, the speech areas, and now mapping it preoperatively where all these important fibers are, and postoperatively still preserving them. So that's incorporating imaging innovation. Now, intraoperative MRI scan, because sometimes when you resect these sort of tumors, they can be quite challenging to know for sure whether there's any residual tumor. Intraoperative MRI is very helpful to help us be more certain of the extent of tumor resection. This can be combined with the intraoperative ultrasound, and ultimately, no matter how we look at it, ultrasound is a very good imaging modality where you will have the ability to compensate for brain shift, whereas MRI scan, usually they are a static scan. Once you have brain shift, then the navigation might not be as accurate anymore. So we combine them all. So you can combine the ultrasound and the MRI, and you can sort of recalibrate them. And you can, in this case, that even though the fiber tracks appear to be here, but once you've recalibrated it, it's been shifted lower down because of the brain shift that has already occurred. And this can be done with ultrasound guidance. So then we move on to skull-based tumors. Skull-based tumors dealing with primarily benign tumors. This is a big meningiomas of the anterior skull base. So you can see after resection, we can show you the optic chiasm and the optic nerve that's been splayed in the back. And this would be the anterior cerebral artery that again has been pushed to the back. So once the tumor has been resected, you can see the vision improved from the pre-op status. Other types of ways to remove these sort of tumors, some of them we can remove them through the nose. Like for example, in this case, it's a pituitary tumor with the giant acromegaly. We go through the nose to remove the tumor. And this is usually with the views from endoscopic endonasal approach. Other tumor that you can remove them through the nose. For example, in this case, the clival tumor. And then another example will be a craniopharyngiomas in the suprasellar region. And some pediatric tumors, like a germ cell tumors, if it doesn't respond to radiotherapy, that can also be removed with the endoscopic endonasal approach. Meningiomas in this area, so the one I was showing was more forward. This one is in the tubercular cellar. So some of this can be removed very successfully through the nose. Now moving on to functional neurosurgery, dealing with movement disorders, pain, epilepsy, spasticity. So we in Bristol here, we have developed some new devices for deep brain stimulation. So these are some of the studies that was shown in the news and also in the paper. And you can see here, so with robotic guidance, we are able to implant this sort of deep electrode to the very specific target in the brain. So in this case, this is going for the globus pallidus interna or subthalamic nucleus to aim for the particular target in order to deal with the different symptoms for Parkinson. And here you can see the different fiber tracks in relation to the deep electrode that we have inserted. And now we move on to spine. So spine, there can be a fracture that we try to either fix or reduce. So this sort of surgery is usually very, very extensive because there's multiple level involved. And it's also very difficult. You can see the bone almost overlap with each other. But with the imaging technology that we have available and also robotic guidance, we're able to reduce a lot of them. And this is an example that was done, multi-level fixation. And in our centers, we also use a robotic guidance to implant this sort of pedicle screws in order to improve the accuracy. This is what it could look like in the future. I think not all the steps are done by robots at this point. So this is a videos of what it could look like, where if it is all fully automated with robots. So at the moment, the steps is done by robots, but the screws picking up, we still do it manually. But the key thing is if the robotic arm can guide you to a specific trajectory, then you'll be able to introduce the pedicle screw very safely. And this is all to do with good planning, navigation, including the robotic arms. So I've shown you some of the examples of the different subtypes of neurosurgeries and some of the innovation that's going on. What about some of the myth and the misconception about neurosurgery? Generally, it's felt that the outcomes are bad. It's not strictly true because I think it depends on the subspecialty that we're in subspecialty with benign brain tumors, for example, the skull base subspecialty, the outcomes generally, if you can get good resection, the outcomes are good, and that's certainly what we want to achieve for our patient. In the functional neurosurgery, for example, where the patients have deep brain stimulation for Parkinson, generally the success rate is very high now. If as long as you get very good, accurate target to the particular specific nuclei that we're aiming for. And then the other one, spine. Spine, generally, we know bread and butter of spine surgery. A lot of them are disc prolapse, degenerative spinal diseases. We know 80-90% of them can have good outcome in terms of pain control. And other things like primary brain tumors, the outcome is not as good because I know that the prognosis is still in the region of 15, 18 months after diagnosis of a primary brain tumors after surgery and chemoradiotherapy. But we know that nowadays with subclassification of the tumors, depending on the genetic profile, some of them could live longer, 3-4 years. There has been cases where primary brain tumors with longer survivals beyond 10 years, but it's all down to the biology of the tumors. But equally, there are some tumors which are still pretty bad. But generally, the outcome being commonly bad for all tumors or for all neurosurgical condition is not true. So it depends on the subtype. Trauma, it depends. So it's trauma, we have certainly had a good improvement in terms of the ICU care. So patient survival has improved, but patients' disability, that's due to the initial insult. So we haven't been able to implant stem cells and reverse patient neurological deficit, but that hopefully will be in the future. The next myth is always about neurosurgeons are being arrogant and being unhelpful, but I think that is certainly different for different centers and different countries. Certainly in the UK and in many parts of the United States, when we go to meetings and when we go to World Federation Neurosurgical Society meeting, you meet a lot of neurosurgeons who usually are very helpful. I don't think, certainly personally from colleagues' point of view, we work in a very collegiate manner. So I think that myth is certainly not true. Too little, too late, that sometimes is said about neurosurgery, where the bleed has already occurred, the stroke already occurred, the head injury already occurred, the tumor is already too big, so therefore there's nothing more that can be done. But as I show you, there are still some areas that we can make certain improvement. I will talk a little bit about this sort of tumor, for example, because my subspecialty is in skull base tumor. So this is a petroclival meningiomas with like a little lip that goes into the internal auditory meatus into the inner ear. So this patient presented with, and you can see there's a lot of brainstem compression with some distortion of the lower cranial nerves. And you can see it's a big tumor, but post-operatively, we'll be able to achieve resection. But even though we have resected the tumor, but what is the price to pay? Yeah, because there's a lot of brainstem structure, a lot of cranial nerves, lower bulbar nerves. Is that acceptable for our patient to have this sort of tumor resected? So from an imaging point of view, we have resected the tumor successfully. But from a patient point of view, you can see the patient has got facial weakness on the left side. This is a House-Brackman grade 4 facial weakness, not able to close the eyes. But you can still see there's a little bit of outline there. But as long as we know that we've preserved the neurophysiological signal, we would do this sort of surgery using electrophysiological monitoring with facial nerve, bulbar nerves, monitoring trigeminal nerve. So given time, this is 3 months down the line, you see that the nerves improve again, because after surgery, you're going to have to peel the tumor away from the nerves or peel the nerve away from the tumor. No matter how we look at it, there will be the trauma of the surgical procedure itself. Therefore, inevitably, we can get the neurological deficit, but as long as we preserve the signals electrophysiologically, then there's a high chance that they will improve. So this is again an example that not the conditions generally bad. So even though this tumor has caused a transient deficit to start with, but given 3-6 months, then the deficit has improved, and you can see this is pretty much back to normal function for the patient, and the tumor has been resected with no evidence of recurrence. So that is considered a very good outcome. And she's a teacher, and when she was recovering, she was writing a book. So I was very impressed with her recovery. And certainly the patient, when you see them doing well, that would be the best reward for our work. So I'm just going to talk a little bit about innovation in meningiomas because that's one of my subspecialty interests. So we trying to use the genomics and the radiomics to help improve the care for our meningioma patient, because not all meningiomas are the same, even though I think it will be considered the most common benign brain tumor. So they're very, very common. Certainly can be seen in 3 to 4% of the population, but they are not all the same. These are the tumors which is very big. These meningiomas are very, very big. And this is a gentleman in his 30s who had the previous radiotherapy when he was a child for leukemia. So 25 years later, this tumor occurred as a result of a radiation-induced meningiomas, late onset. But he's in his 30, still in his young age, and we cannot leave this tumor behind without treatment. So we incorporate surgical resection. So I was able to resect this tumor completely. You can see it is a good resection. Even though there are different components of the tumor, there's a component which is on the tentorium, and there is another component which is infratentorial, meaning it goes below into the posterior fossa, pressing on the brainstem. And then this component here higher up at the level of the ventricle. So we had to be creative and have different corridor to remove this tumor, incorporating the subtemporal approach, the infratemporal approach, and also the transcortical approach, and able to achieve this resection. But the question is, do we think that this tumor would not come back? I think it would be naive to believe that it will not come back, because even though we have had a good resection, this is a radiation-induced tumor. Therefore, we have to think a bit harder. How can we reduce the risk of it coming back? Can we incorporate some sort of genomics? We have sent this off for genetic testing to look for the various mutation markers. And is there any imaging features like a radiomics feature that could help us predict whether it is or isn't to come back? So this the talk, the next part of the talk that I will be concentrating on, whether we have made any progress on this. This is another example in a young girl. She has medulloblastoma. You can see she had previous surgery in the posterior fossa, and then 20 years later has a radiation-induced meningioma. This is affecting the petroclival region. We were able to resect this, but the rest of her dura is also very diseased. So therefore, this is another case where surgery is not the only solution for this patient. This is a patient I did recently, a gentleman in his 50s with giant anterior skull base, tubercular cellar, anterior clinoid meningiomas. So even though we resect them, the result is a WHO grade 1 meningioma. But do we believe that all WHO grade 1 meningiomas behave the same? The answer would be a no. So I'll just talk you through a little bit of our improved understanding on meningioma now. So meningiomas is not all the same. This would be a paper from over 10 years ago, 2014. It was published in Nature. Talks about the different subgroups of meningiomas that harbor genetic mutation and where are they more commonly found. So you can see in this example, NF2 associated mutation meningioma more commonly found in the convexity region, in the posterior fossa, and if you have an AKT1 mutation, more likely in the cruciform plate, the clival region, SMO mutation in the cruciform plate. So this is something that we have worked on, and it does help. So now we know that meningiomas, even though it's a surgical disease, but 20% of them can recur and would need further treatment. And when it recurs, is surgery the only treatment for it? The answer would be a no. So we need to make improvement to help understanding on the biology of this tumor. And the biology comes down to the behavior with the genomics, the genetics profile. So if you can combine the genomics and the radiomics feature, then hopefully we can then predict which tumor is the one that could potentially come back, which potentially would be behaving more aggressively, which would be the one that can be more benign, and then you might be able to say you don't need surgery, you can be left alone and just not needing any further intervention or any follow-up. So currently, based on our understanding on WHO grading of meningioma. This is has been used for nearly 100 years. We still grade them into WHO grade 1, 2, and 3. This is our basic understanding of meningiomas. So we understand that grade 1 tumors are very benign. Usually they don't come back. There's a 5 to 10% chance it could recur in the next 20, 30 years. This is what we believe about grade 1 meningioma. Whereas grade 3 meningiomas, they are usually very aggressive, tend to recur within a couple of years. And grade 2 meningiomas are the one in between. But are they all the same? Do they all behave this way? The answer is no. So why? Because of further features of things that people have since found. So this is an updated WHO classification to clarify the genomics feature for meningiomas. So they have now included chromosomal losses, 1p22q losses, other DNA losses, including different chromosomes. And then they also look at the genetic profiles, including the methylation status. These are all the things that indicate it's low-risk patient, and these are the things that indicate high-risk patient. So what does it mean eventually? So essentially, it's not just about the WHO grading itself. It's about building up the WHO grading, including the chromosomal losses changes, the methylation status, and also the DNA changes. And then you subclassify them further. So you can see that some tumors, even though they are WHO grade 1, but if they have some aggressive features, it could be upgraded to become a WHO grade 2 tumor. And this is a methylation status paper that was published. And I'll show you, this is what we usually talk about WHO grading. WHO grade 1 tumors being benign, WHO grade 3 being more aggressive. This is a performance, this would be the progression-free survival for the tumors. So it is showing that yes, grade 1 tumors more benign than the aggressive tumor. But if you combine the methylation profile, this is now including the methylation profile. They have subclassification 1, 2, 3. This is the intermediate grade, and then there's a malignant grade. You can see that once you have subclassified them further, then the lines become even more obvious. So the malignant tumors, they become very aggressive and they can come back. This is between 100 months, 50 months, so that's 3, 4 years. Whereas previously, WHO grade 3 tumors, some of them could even take up to 10 years before they come back. So whereas the benign tumors, you can see that a lot of them, 80% of them, don't tend to come back beyond 10 years. And this has been shown to have stronger statistical power if you incorporate the methylation status. Now, the methylation status has been done by many, many different groups in the world. So this is a diagram that shows that even if you are WHO grade 1 meningiomas, some of it could behave aggressively. So this is a grade 1 tumors that has a intermediate B features, for example. And then this would be like grade 3 tumors. Traditionally, anything that's papillary, that rhabdoid would be considered grade 3 tumors, but papillary tumors might have a very intermediate profile. So it's not a grade 3 tumors. So rhabdoid tumors might even have like a benign profile. So therefore, it might behave like a grade 1 tumor. So the grading of WHO itself is not sufficient or accurate enough to predict the biology of the tumors. So we can see that we have since done a lot of work looking at the different genetic mutation, the methylation status, and these are some of the groups that was published in Science and Nature over 10 years ago, knowing about the genetic changes for meningiomas. So we also do some work looking at olfactory meningioma. This was published in Journal of Neurosurgery a few months ago. So what do we see? We show that AKT1 mutation tumors. I did show you one of the slides showing that anterior cribriform plate mutation meningiomas can have either AKT1, SMO mutation. So you see that those with AKT1 mutation generally they're not as aggressive as those with SMO mutation. SMO mutation tumors are generally bigger, and they tend to have more aggressive biological behavior. So what about the AI part? So the AI part is our little effort to try to see if we can incorporate the AI imaging to see if we can predict the biological behavior of these tumors. So this is a pilot studies that we did. We're currently submitting them for publication. So we incorporate the methylation profile, the WHO grading, and subclassify them into the integrated meningioma score, not using the WHO grading itself. And that is used to predict the tumor progression. So we have nearly 80 patients in our cohort that we look at this, look at for these studies, and we are able to include our meningiomas, including the preoperative imaging finding, the DNA methylation status, the WHO grading, the genomic status, and then we then do tumor segmentation of the MRI imaging preoperatively, and then we feed them through the AI models. So there are three models that we feed them through. The first one is the radiomics-based machine learning model. The second one was the CNN model, convolutional neural network model, and the third one is the vision transformer, the VT model. So what do we see? What do we see? You can see that after we incorporate all the various characters, the integrated risk score is slightly different to the meningioma WHO grading itself. But this is the key part, the model number one, the accuracy is not as good. It's in the region of 80%, model number two about 90%, and model number three as high as 99%. So what this is showing to us is with AI and radiomics, we might be able to have as high as 99% accuracy prediction on the biological behavior of this tumor. So this is a single center study. So in theory, we will need to have further validation in order to check that this is something that we can replicate in other cohort. And that just shows us that incorporating the innovation, the AI models that we have, we could improve the care for our patients because there will be a lot of meningioma patients, as I already said. Some of them might not have as bad a behavior, so they might be okay to just be monitored either with imaging alone. Some of it, even though it might look small, but would need surgical intervention early on. But there are limitations with our studies. It's less than 80 patients and a single center, so we need to have a bigger cohort of patients to prove this concept with AI and radiomics characterization. So this is an example of the tumors that we resected recently. I'll just play a little videos. So ultimately, as surgeon, we still want to be able to do good surgery for our patient, but this is a very challenging operation. You can see there's middle cerebral artery coming off, and there are tumors sort of wrap around the vessel. So we need to be very careful to preserve the vessel. And this sort of surgical resection, you want to be able to remove the tumors and also preserve the anatomy. So the key thing is actually knowing where the anatomy is. And this middle cerebral artery, we can see these little perforated vessels. You have to save them all. And now we're looking for the anterior cerebral artery. Now the tumor section, freeing up the anterior cerebral artery. So carefully debulking the tumors, reduce the size and the volume, and then working along the vessel itself, remove the tumors very carefully. And the key thing is if we do not preserve this vessel, then they will have a big stroke, and then you certainly will have bad outcome for our patient. But sometimes, even though we think we've done the best surgery, now we're seeing the optic nerve. Even though we think we've done the best surgery for our patient, in some cases, we might have to leave a little bit of tumor behind. So in this case, we're able to remove the tumors from the ICA, from the ACA, from the MCA, preserving all the perforators. But there is a small tumors that I couldn't get from the optic nerve because I know that if I try to take the tumor away from the optic nerve, then I will blind the patient. So I have to leave a little bit of tumor behind that's stuck to the optic nerve. And that tumor itself that's stuck to the optic nerve, what will happen in the future? Now, ideally, I'll just fast forward. Now, you can see there's the optic nerve here, splayed, and there's like a ribbon of thin, very thin optic nerve. And in order to remove this tumor from the optic nerve, if I'm too aggressive, then I would damage the optic nerve. So that wouldn't be ideal. Now we're trying to incorporate different technique. This is opening up the anterior clinoid. I'll just fast forward a little bit. We can open up the anterior clinoid and then drill off, because I know that the optic nerve will go into the optic canal. And when you drill off out the anterior clinoid, then you'll be able to see the optic canal better. But still, when I remove this tumor, you can see the optic nerve is being displayed. So that wouldn't be very safe if I'm being aggressive and try to remove all the tumor from the optic. And you can see now the optic nerve is very, very thin, and it's moving as I'm resecting the tumor. So I decided to leave a little bit of tumor behind. And that tumor, how would it behave? That would be down to the behavior of the tumor biology-wise. So we send it off for all the genomic testing. So if it were to recur, then at least if you harbor one of the mutation, for example, AKT1 mutation, then we can use the AKT1 inhibitor as a treatment to deal with the recurrence rather than trying to go for further tumor resection. So that's the idea behind trying to incorporate the genomics for these sort of cases. And this is the post-op scan. So in summary, we know that even though meningiomas, they are surgical disease, but 20% of them can recur and would need retreatment. So when we incorporate the genomics and the radiomics, that would help us to hopefully predict who this 20% will be and monitor them closely. So the last part is about advice coming to neurosurgery. I think a lot of us, we look forward to get very good training. So United States of America is always perceived as the best center in the world for anything, for medicine specifically. So for us, we always want to aim for the stars. So what are the time where you can go and get American experience? I think medical school elective is very good. So I went to the Mayo Clinic during my medical school years for my elective. So that's certainly a good time to try to find out what the things, in first-class centers in the world are able to do. So reach out to them and spend some time with them for medical school elective. During registrar training or residency training, that can be another time. But the training is currently certainly very hard. If you're trained in the United States, then it will be preferred to go to the United States after you finish medical school. So you probably need to do some sort of a internship research program in the US for you to get into the system before you can apply for the residency. Or you could do residency in your own country and then go as a fellow. So the fellowship training, then you already qualify as a neurosurgeon. So there are a lot of centers that will accept fellows, foreign fellows for American experience. And as a consultant, there are some people who become very good in what they do, and they might then move to the United States later on as a consultant or as an attending. So those are all the potential period where you can get American experience. But I think from my point of view, you could certainly try. Like myself, I've done medical school in the Mayo Clinic and the fellowship in Stanford. So you could try more than one. So that's trying to get the best experience and try and see how we can then benefit our own patient. So I think in conclusion, if you want to be very, very good as a neurosurgeon, you have to find good mentors, seek the best and learn from them. And always believe that change is constant. We're not living in a world where everything is static. So we have to be able to change ourselves, evolve. And as you can see, the neurosurgical practice itself has got so many subspecialty. And there are things that we are doing nowadays that will be changed when you guys are practicing, for example. One of the example is endoscopic spine surgery. So we do microscopic spine surgery currently. But in the future, I think there will be a lot of movement towards endoscopic spine surgery. So we have to learn to keep up with time. So the other one for skull-base surgery, for example, there's a lot of move towards transorbital approaches. So rather than trying to go through the nose, so some things there's a bit more anterior, for example, or a bit more lateral. So rather than a craniotomy, you might be able to go through the orbit and get to the tumor that way. So change and evolve and learn. Priority in life changes. So I know that we all work very hard and when we're younger, but as we get older, priority might change. You might find that life might be more important than work. But certainly, neurosurgery is a good career, but we need to have a life outside of our work. So going skiing, enjoying the sea. And this is a slide that I really, really like. So this slide shows um, the evolution of mastery. This is taken from Michael Lawton, who is a very famous vascular neurosurgeon in the world. So you can see that the total number of aneurysms that he has performed is in the thousands. So in our generation of neurosurgeon, we will not reach this kind of numbers. So we will not reach thousands in order to achieve this different level of mastery. But does it mean that we will never become good? So it shouldn't be like that. I think even though the numbers might be lower, we would learn from our masters. So therefore, we stand on the shoulders of the giant and we actually learn their mistakes. So therefore, rather than starting at this stage of curiosity, we probably will start at the step of discipline. So even though our numbers might not be 1,000, we might be at 100, and then we start at this stage. So the first 100 will be your building out your learning curve stage. But once you have reached 100, then you can go on and improve. So you wouldn't be in the thousands, but each time you do aneurysm cases, rather than going in fresh, we would have done all the practice beforehand, incorporating all the technology and the innovation that we have. For example, 3D printed models, all the 3D anatomy, the simulation models, the AR, the VR. So all this needs to be taken into account when we practice ourselves, kind of rehearse the surgery in our mind beforehand, before we do the real operation. So that will certainly improve our outcome. So these are some of my teachers who have guided me throughout my career. And our work wouldn't have been possible without a lot of collaboration from all these various people, as you can see, including the team of engineers on the AI work. Thank you very much. So I'll open to some questions if you have any questions.
Yeah, thank you so much, Dr. Theo. That was such an insightful talk, and you really gave us a good overview of all of neurosurgery as a specialty. I wanted to ask you more about your work on meningioma. I found it really fascinating when you spoke about the biology and how we can work towards creating something that can accurately predict the rate of recurrence, as you said, and especially your pilot study using AI, achieving even in a single center, achieving an accuracy of about 99% is a big deal. It's pretty unprecedented. I was wondering, how do you plan on, of course, expanding this to multi-center studies? And then when do you see this in a timeline fashion coming into actual surgical practice so that we can, detect with a bit more confidence on how we want to manage a particular patient, if it's going to be purely surgical or also medical or a combination. Yeah.
Yeah, no, very good question. I think the timeline is going to be pretty soon, I have to be honest, because we wouldn't be the only center that do this sort of work. There will be this sort of AI radiomics work that other people are probably doing at the same time. Yeah. So the next step from our point of view we have reached out to a few centers in the UK, and then we're going to validate our results based on their samples. And if it is something that also apply, then we're gonna reach out to international cohort. And as you have seen with my training, I've been to many different centers in the world. So I do have connections in the United States, in Asia, in China. So it's not hard to reach out to people and get this sort of collaborative work. So I would say in the next few years, certainly when you are training, so a lot of you are in the medical school at the moment. I think in the next 5 years, this would be validated, and then it would become the norm. So by the time you're training, it will become the norm. So like my training, we 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 kind of heard about the genetic changes in meningiomas, but we still believe that they're all surgical disease. We would just all meningiomas, we just have to resect them. If they're not resectable, then we can give radiotherapy, and then pretty much palliative radiotherapy, because ultimately we have been brought up in a view that meningioma is a surgical disease. But nowadays it's shown that actually not, like we have learned a lot from other tumors. So the AKT1 inhibitor, SMO inhibitor, for example, these are inhibitor that has already been used for other tumor types. So if you prove that our meningioma has this mutation, then in theory, we could borrow those medication from other
Right.
tumors and then apply to our patient. So this work will be validated. So at the moment, we are sort of working on the different subgroups. So we're working on the different types of meningiomas, and then we're gonna want to prove that this genetic mutation actually exists. And then currently we have worked on olfactory meningioma, so we work on a tuberculosis meningioma. So the next step we work on cavernous meningiomas, patch-clever meningioma. So that's all the collaborative work that we're working on. The AI work, like I said, we're gonna link up with a few centers in the UK, and then we're gonna work on a few centers in the world. And in the parallel, we also work on vestibular schwannoma because when you think about this sort of AI prediction, all that we want to know is growth, tumor growth. And if the AI can tell us whether there is tumor growth or not, then that would help the imaging, the radiologist in reducing a lot of the workload for them, right? A lot of time, I don't know, some of you might have come across multidisciplinary team meeting where we're debating whether is there growth or is there no growth for the tumor. But if you can put an AI automatization where the computer will tell you whether there's growth or not, then that would take the debate out of the equation. So we're working on trying to work on that for vestibular schwannoma at the moment. So some of the audience might have medical students from the UK that might have worked with me, and we're currently working on some of those projects. I see there are some questions.
Yes.
So
Okay.
Dr. Marcel, yeah?
Yeah, Hangai, could you please introduce yourself and ask your question, please?
Yes, yes. Thank you so much, Professor Mario. I'm Dr. Ayank Edimas. I'm intervening from Uganda. So thank you so much for this very informative presentation. And in terms of the innovations, I wanted to know in tumors or aneurysms, what are like the advantages of awake surgery, awake craniotomies, like when you're intervening around lenticular striate vessels? What are the advantages in preventing like the post-op complications due to hypoperfusion to internal capsule or basal ganglia? What is your experience in terms of awake surgeries if you're intervening in aneurysms? Another question could be in terms of brain mapping. Brain mapping, when it comes to advantages, what could be the advantages of brain mapping when it comes to like in refractory epilepsy? When you want to do a lobectomy or a spherectomy, what could be the advantages of brain mapping? Those are like the two questions I had. What could be your experience in terms of that? Your advices to us who are still learning.
Yeah, so thank you for the questions. We have fellows who train with us from Uganda. You might want to reach out. So there's a professor neurosurgery called Blessing Tarimwa. I think he's in Kampala. So
Yes,
reach out.
yes, I know. Dr. Blessing is in Mbarara.
Parallel, okay. So yeah, so for the first question is about awake craniotomy or awake craniotomy for aneurysm. So I know Professor Abdul Rauf does awake craniotomy for aneurysm, but I think in our center we don't do that. I think from a awake craniotomy point of view, there are benefit for sure. A lot of it is about the benefit of intrinsic tumor resection. I think that is probably more important because for aneurysm surgery, you want the brain to be very, very still, for the dissection that we do. So nowadays we do very small opening. I do like a very small mini terminal opening for brain aneurysm. So if you have the patient awake, then it's less predictable. There might be trying to interact with you, then the brain might not be as relaxed as you like when you're dissecting the ciliary fissure. So in my practice, I don't do that. I keep the patient asleep. And the key thing is about preserving all the vessels you can see. I think that's where indocyanine green is very important. We can see, and the Doppler. So you can see all the different perforators and very clean, meticulous dissection of the ciliary fissure and the little perforated vessels, just like some of the dissection that I showed for the tumors, like very clean, very careful dissection of the vessel. So if you preserve all the vessels, and then you secure the aneurysm, as long as you preserve all the vessel, in my personal experience anyway, I don't see that there's additional benefit with awake craniotomy for aneurysm surgery. But certainly it has a role for intrinsic tumor resection. For example, if you're mapping out the speech area or the motor cortex in certain pathology. Now, in terms of the type of awake craniotomy, everybody do it differently. Some people do it awake throughout. Some people do asleep, awake, and then asleep. So it depends. They will awake the patient to map it, and then once they've mapped it, then they will put the patient back to sleep for the precise reason when when the brain is all calm and relaxed and patient is asleep, then there is no movement. Then your control of your resection becomes more easy. I guess easy might not be the right word. I guess more control or more manageable. Now, in terms of the mapping itself, you mentioned about mapping for seizure. This a lot in our centers we do them preoperatively, so they will get like a EEG monitoring or depth electro EEG monitoring to map out the functional epileptic focus, for example, and then they can then um, plan around how far is the seizure zone, and then they can then decide in the multidisciplinary team setting with the neurologist, epileptologist, the neurosurgeon, get all these EEG signals, information available, and plan for their surgery rather than mapping it on the table. Unless it's a cortical mapping, most of the time you see that for my colleagues who do epilepsy work, they would have done the EEG implantation beforehand. And if you want very, very accurate implantation, we incorporate the robotic arms because robotic arms are very helpful to get the accuracy of the implantation for the deep structures. I hope that answers your questions.
Yes, thank you, Prof.
There was another question from
Yes, Marwan, go ahead, Marwan. Are you there, Marwan? Jobber? Perhaps not. Atta, do you have any questions or comments? Go ahead, Atta.
Excellent, Professor Theo. I'm impressed with the vast topics you covered in 40, 50 minutes. You gave an excellent overview and almost touched every specialty. And that's the best part of your presentation. I'm a neurosurgeon. I'm trained in neurointervention as well. So my concern, my question regarding this vascular and technology is how it's impacting the future of vascular neurosurgery. Not only technology, but also the alternative modality of treatments than microneurosurgery. So how endovascular, and that's killing the field for neurosurgical dominance. So at times we are no more in the main horizon of that all treatment management. What's your
for vascular neurosurgery? You mean for vascular neurosurgery? Okay. So I think it depends on how we look at vascular neurosurgery. So vascular neurosurgery nowadays, when we train in the United States, some of our co-fellows, they will train, so they can do both vascular and open surgery. So therefore, they have the best of both worlds. You know, they can manage aneurysms with endovascular treatment and also with the open surgery with clipping. But the key thing is that they will have to manage most of the time for interventional work because the workload of neurovascular surgery or neurovascular condition, if you think about it, stroke work is a lot more common than aneurysm work. So the incidence of a stroke is usually 100 per 100,000, whereas aneurysm is 10 per 100,000, so 10 times more common. And when you look at cases that will be eligible for stroke thrombectomy, even though you say 10-20% of them, there's still more than brain aneurysm. So therefore, as a future uh, vascular neurosurgeon or vascular neurosurgical experts, you will have to be able to deal with stroke cases. And then there is other evolution that's coming on. So like chronic subdural hematoma, for example, people talk about MMA embolization, and there has been RCT that proved that. So again, you're going to have to do that as part of your expertise in vascular neurosurgical condition. So this is a model that American is taken, and I think that is a good model. A lot of centers in the world are going with that. Will we be phased out because of the dominance of interventional work? It depends. I think if you embrace it, then we wouldn't be phased out. I think if you embrace it, then we will become part of them. If we try to kind of exclude ourselves from interventional, then open microsurgical work will become almost yeah, it will get phased out because I think people would then feel like, oh, I haven't done an aneurysm clipping or I haven't done a bypass, so therefore it's not safe to do. And as a result, as time goes on, then there'll be less and less people able to retain this sort of expertise, and then we will lose this microsurgical skills. But I think it would be a shame that we, as a younger generation of neurosurgeon, we should preserve those skills that has been developed by our predecessor, Professor Yazgil, you know, that has um, like taught so many of us on the microsurgical skills, and we have very good opportunity to practice. And I host a bypass practice course last week, and so we can practice on silicone tubings. We can have a at home microscopic station that you can practice all these microsurgical skills. So that kind of technique, you don't have to you don't have to do it on a human, but you can practice it on chicken wings, on simulation models, on 3D printer models. So all those skills can be retained by us. And then when we do have the patient, small numbers, yes, but when we, like I show you the slide of Professor Lawson, even though it's small numbers, but hopefully we can achieve the excellent result that some of our teachers have been able to achieve. But that's all to do with practice. I remember there's a talk from Professor Luca Reckley from Zurich. He says, as neurosurgeon, we perform a lot, but some of us don't practice as much, you know. So, for example, if you look at tennis players, they would have practiced for 6 months a year, and then they go for a tournament for 3-4 months a year. You know, so you can see they therefore spend a lot more time practicing than performing. Whereas as neurosurgeon, a lot of time we go into the operating room and then we just perform. And his point is that we need to spend the time practicing to make sure that the skills that we have is retained to the highest level. And I think from my point of view, yes, the numbers are not going to be high. So bypasses, I would do about 20 bypasses a year. It's not going to be hundreds of bypasses. Aneurysm clipping, we do about 10 a year. It's not going to be 100 a year. So the numbers are small, but we still retain the quality of the surgery that we do. And of those that we do, we have to make them count and make sure that you don't you do your best to have the technical skills that you have to deliver the kind of cases.
So I'm sorry to interrupt. I just want you to comment on UK model of neurovascular. Are neurosurgeons allowed to practice hybrid? First thing. if they are hybrid trained, are they into ischemic stroke team? Are they part of ischemic stroke team? Neurosurgeons trained in neurointervention. What are the criteria for credentialing?
Yeah. So in the UK, we have 30 neurosurgical centers. Currently, there are 3 centers that has the hybrid neurosurgeon that's involved in the stroke work, interventional work. So I think in the future, we would hope that there are more centers that will be willing to adopt this sort of practice. And I think it will be a matter of time. Certainly from a regulatory body point of view, they have had credentials that has been set up for UK neurosurgeons or for anyone. They say as long as you go through the training and get the credentials to do thrombectomy, endovascular intervention, then you can take part in delivering the services for endovascular work. So the key thing is the credentialing. The credentials has been drawn up, and it's down to the individual to actually take that on. And then the service itself, would the service encourage that model of a dual trained neurosurgeon? At the moment, like I say, it's a small numbers, but we'll be hoping that in the longer term, it will be a bigger number like the United States. I think in the United States at the moment, interventional work, I would say of the colleagues that I've known, a lot of them are neurosurgical trainees to start with, and then they go into interventional training, and then they also do some open surgery. So their workload is usually, they say to me, 70 to 80% interventional and 20 to 30% open surgical. And that seems to be how the balance they have made able to manage.
Yeah, and if I'm allowed to add, India and Japan also has many neurosurgeons doing neurovascular in dual mode. So, but my information regarding UK was that the only radiologists are into ischemic strokes so far.
Yeah, that's why the changes has we all know that the models in the world, US, India, Japan, China, Egypt, so they all have incorporated the hybrid training, and I think the UK, we have to follow. I think, like I say, if you don't change, either you embrace the change or you get left behind.
I am currently doing an endovascular enfolded fellowship, and I'm a neurosurgeon myself.
Excellent.
Yeah.
Okay, thank you. Now, Marwan, can you introduce yourself and ask your question, please?
Yeah, sorry before I couldn't open and talk. But yeah, thank you, Dr. Mario, and for this amazing lecture. I really appreciate it. And thank you all for this amazing discussion. Dr. Mario, I had a question. Of course, it's not mine, actually. A friend asked in a previous webinar before, and Dr. John knows about this, regarding quantum dots in neurosurgical research, regarding specifically drug delivery or even high resolution imaging, or even like to differentiate in between like tissues and neuro-oncological surgeries. Like, do you have any ideas about it? Because like I read a lot about them, but still doesn't get like how is it specifically? Like, have you seen them? Have you read about it? Or is it like if you can like tell me about them in a short.
Come again,
Quantum dots.
I'm not familiar with that. I think that's maybe a too futuristic. I think at the moment it's probably something that will come, but I'm not familiar with that. Like my subspecialty is not um, intrinsic brain tumors. Like I do some intrinsic brain tumors, but I will have to say there will be professor of neuro-oncology perhaps that will do this sort of work, but I'm not familiar with that.
It was already in preclinical research, so I still think so. But yeah, thank you. I really appreciate it.
Thank you.
Doctor, this is probably the one time in history there's been so much change in neurosurgery. I know you had to learn the basics, but now there's other things that neurosurgeons are going to have to, even older neurosurgeons have to learn new stuff. And not just the classical evidence-based stuff. So it's exciting time in history.
Indeed, yes, indeed. Yeah,
Okay,
that's
any more
right.
questions? Or Uday, do you have a question or comment? No? Anybody
Yeah,
else? Go ahead. Go ahead.
yeah, I want to ask from Professor, from scar-based tumors, is there any advantages of using endoscopy surgery or using an exoscope? Like nowadays, there are too much on exoscope. So I wanted to know maybe if Professor Mario has some input on the use of the exoscope and what could be the advantages on the use of endoscope.
Yeah, so
Because like,
for
yes.
for microscopic surgery, like a lot of the time when you put endoscope in microscopic surgery, it helps to see around blind spots and corners, so it's always helpful. Like for example, if you have a vestibular schwannomas that you resected, and then you're trying to look into the IM, then the endoscope is always very good. You would have drilled out the IM, but then you could introduce the endoscope, and then you can see a little bit more further into the IM, and vice versa. If you have drilled off the Kawase triangle, for example, but you want to look up from an inferior corridor. So if you've got done like a retrosec and you've done a petroclival meningiomas and you think there's some tumors that's up into the Kawase triangle. So we can drill off the petrous apex from the back, but to look up might be very hard from a retrosigmoid corridor. Then endoscope is always very helpful. So I do that for my surgery. Exoscope, it depends on the use of exoscope. So at the moment, exoscope has limitation. And I would have to say, we are neurosurgeons trained to use microscope. Like most of us train with microscope when we're younger. So the line of sight for the microscope is the same as what we see, whereas exoscope is slightly different. You still have to imagine, exoscope usually come at an angle to what we are actually seeing. So the hands kind of have to compensate to the line of sight of the exoscope itself. So that is not very intuitive for all of us. So some of us need a bit of time to adjust to that. It will come, and that kind of adjustment is easier to do for surgery with a little bit more error for a little bit more um, margin for error. For example, spine surgery, ACDF microdiscectomy is very easy to convert from a microdiscectomy to an exoscopic discectomy. You still do small incision, and the visualization will be as good. And even though the angle might be a few degrees different, but your hands adjust to it very quickly, and you know that the marginal error is not as narrow. So therefore, even though some parts you might not be able to see as clearly, but your brain, from all the microscopic training, knows that, okay, this is where the lamina is, this is where the nerve root is. Therefore, you still feel comfortable doing it with the exoscope. So I can convert quite easily for exoscopic surgery, for ACDFs and spine surgery, microdiscectomy, even certain parts of spinal schwannoma, for example. But for cases like a bypass or for acoustics, I still find it difficult to convert completely to exoscopic surgery. The reason is because, like I said, this the line of sight, and the color is slightly different. Like to us, when we look at the microscope, we are already familiar. The color that we see is natural color. So whatever we see on the microscope is just magnified for us. So the color is still the same. So our brain learned that, okay, for glioblastoma, it's slightly different to your brain tissue. So the brain already knows that. And when you're under the microscope, you are able to more confidently resect the tumor from the brain. And when you use the exoscope, the color is slightly different because these are optically engineered colored, especially at very high magnification. And then we put on 3D glasses, like 3D 4K screen, and suddenly it become a bit more red, a bit more green. Then your brain have to relearn this color. So I find that difficult for very difficult for like um, intrinsic tumors, especially the eloquent one. The non-eloquent one is okay because you know that the marginal error is a bit wider, so you can get away. But when I do the superficial work, it just looked like, okay, maybe a little bit green. I think it's the fissure. I think it's the cistern. But when you cut it, it might be the vein, you know. So the color is just something I still have to learn. So I think there is still a little bit of adjustment that needs to take place for it to be as good as microscope. I have to say that at the moment, in my personal experience, some cases I still prefer the microscope. So we have the exoscope, as I showed you, we have the robotic exoscope. I don't use it for all my cases. In a lot of my cases, I will use them, and at some point, if I feel out of my comfort zone to continue with the exoscope, then I'll convert to microscope.
Okay, last question, Marwan, go ahead.
I'm really sorry, doctor, that I'm asking a lot of questions and taking off your time. But as you were mentioning, I heard you mention over and over schwannomas, so it got in my head. I had like this previous question that I wanted to ask someone who's really experienced. Maybe if you can answer me this. A year ago, we tried to compare surgical approaches for CPA tumors, like schwannomas or cystic neuromas. We did a meta-analysis about it. And we found like we had our results and it was really good, but when we submitted to the journal, it got rejected both from really big journals. But one of the comments was that regarding eligibility of the tumors, whether all the tumors were eligible for all three approaches. So when you compare, you're actually comparing the approaches. But then when we looked at it, not all tumors were eligible for all approaches. I mean, it depends on the ICA extension, the size, whether it's intracanalicular or not. So each place or each, if it has an extension, I think I'm not very well knowledgeable on this, but like it depends on each one. So you will go with which approach. So then how do we compare between these approaches? I asked another research big name, like who's really into research, but not into neurosurgery. He told me that then you should do a prognostic comparison where you compare the prognosis of tumors eligible for the translabyrinthine, let's say, and the prognosis of tumors that are eligible for the middle fossa or the retrosigmoid. So if you can, what do you think about this?
There will be a different talk. I think I do retrosig and translab, and I think you're right. So middle fossa approaches is not done as much nowadays. So middle fossa approach classically is for small intracanalicular tumors, but we don't resect them because we know that in the visual schwannomas, 10 to 15% of them do not even grow. So therefore, the small one, we just monitor them. The medium-sized one, we send them for gamma knife. The large one, then we go for surgery. But the large one, which approach do we choose? Retrosig versus translab. So that's another paper that we're writing currently. In terms of a systematic review, there is a way to try to make it more comparable. If you want to, you can reach out to me. We can look at your papers and we can try and see whether we can improve it to make it more acceptable for journal publication. Ultimately, the bottom line is you need to be able to compare like with like. So that's where we do match pair analysis, you know. So you try to like homogenize the baseline comparison of the two groups. So if you can achieve that, then we should be able to say methodologically we are able to reach that, and therefore whatever conclusion that we draw might be more valid. Middle fossa, I don't think you can go into that group because they're dealing with very different tumors.
Oh, okay, okay. I think you meant fix the baseline characteristics, like which is I think the confounding, right? Like
Correct.
to fix it. Okay, okay.
The
Thank you.
size of the size of the tumors. So usually the size of the tumors, the IM component, and then the other one is the sinuses, you know, the sinus.
Okay,
Yeah.
okay. Thank you. Thank you.
Peaches bone, size of the
Okay, Isha, go ahead.
Yeah, doctor, I wanted to ask you a little bit more about the electives. And you mentioned earlier that you'd done electives during your training as well. I think for a lot of students, although really exciting, it can be slightly nerve-wracking as well because, of course, you're working with doctors that you really look up to. I was wondering, what advice would you have for students on, I guess, during their clinical electives? How do we integrate ourselves into the team, or what are some things that you maybe appreciate from us while coming into a unit like yours?
So I think the key thing is being dedicated and being enthusiastic, you know. So there are some students who come in and then they are almost maybe too shy, but to being shy will come across as being passive. So when somebody is passive, that usually means that the perception anyway, people perception will be, oh, they're not very interested, you know. So even though it might not be the case, so I think one thing that we have to overcome is the shyness, you know, like being shy, then it doesn't help us progress, right? So when you go to a place where you want to learn the most out of it, even though you might feel shy, you have to get the courage enough to be able to engage with them. So it's not just about engaging with the neurosurgeon itself. You need to be able to engage with the team, right? So the team that you need to learn from include the nurses, the registrars, some of the junior doctors, and also even their secretaries, because you need to know that this neurosurgeon, like we all have very heavy, busy commitment. So you want to find the opportunity to spend time with the particular neurosurgeon that you want to learn from. And then where would you gonna find out the timetable? The secretary, you know, you won't be able to find out otherwise, right? It's the registrars, the SHOs. You're gonna be able to learn how the surgeon do things. You might be able to learn about the preoperative care, the postoperative management, the walk around style, the clinic style. You know, that's very important. The nursing stuff, because the nursing stuff would have known the doctors for years. Like some of my nurses we work with for 10 years, whereas the registrar, they change, right? They change every few 6 months, every year, maybe. So it depends. But if you want to be getting the most out of the clinical elective time, you need to plan, you need to be able to get to know people, not just the surgeon itself. You need to know the team, right? The team members, and definitely show a lot of interest and don't be shy. I think that's key. And then the other thing is have some sort of a lot of people want to come and have a project, you know. So you could say, oh, what project do you have in mind? So that is important, but sometimes if you have a idea years already, you know, that kind of helps for the surgeon as well, because you're not just coming with a blank piece of paper. You come with an idea, and the idea can then be tweaked or can be improved. A lot of groups has ongoing studies. So when you have a little project, then that's almost like a proof for yourself that you are keen and you want to deliver. So once you've delivered it, then they'll say, okay, yeah, by the way, I've got another project. Would you be interested in taking on? You see what I mean? So that's just like a good opening line for the interaction.
Yeah, this
Okay,
is
yeah.
a good example of using technology well. Doc, a lot of questions. The students weren't shy and they're doing the right thing. It's great. I'd like to thank you for your time to answer all the questions.
Thank
And we
you.
hope to see you soon.
Thank you.
Okay, thanks everybody. Okay, way to go, you guys. I mean, that's how you can use this Zoom. This is how it should be used. You know, not just a lecture. You can see that on YouTube by yourself. But you guys were interacting, asking questions. Marwan, you have a good lead. He left you a lead to do some research with them. He said something where you can follow up with that, right? And you can write to him and say, you know, I'd like to continue that thought that you mentioned. And that's how it works. You're networking with, he's a big neurosurgeon. I've heard his name for a while. I don't know neurosurgery great, but I know he's got a big name. And to be associated with him in research would be a plus for you. So,
Hopefully, yes. Yeah, you're right.
well, that's
Hopefully.
how it works, man. That's how you get a break like that. You won't get those breaks if you don't ask questions and get involved. But you'll get a break from somebody. You'll get a mentor. You'll get someone like that that's well known. Too bad Shahid didn't get a chance. I'm sorry we didn't have the time. I can see
It's fine.
you wanted to ask a question. You were at the bit. You were ready to jump in. But anyways, Okay, Omar, there's a neurosurgeon from Syria. Omar, hello, Omar, welcome. We can't hear you, Omar. I don't think your mic's working. Well, we can just imagine what he's saying. He's from a place where there is war. I mean, I think there's an active war there now in Syria. We want to do a grand rounds from Syria, but I guess they don't have interest. Omar, what is the story? You can't get the neurosurgeons to do a webcast? We can't hear you. Can't hear you, Omar. Can't hear. No, oh well. To be imagined. So, okay, very good. Anything else you guys want to say? So, okay, great. Oh, let me show you what's coming up. Okay, real quick. Hold on. Just let me show you. And you're very welcome to come to any webinar that we have. And you see it on the website, get the link. Okay. Okay, this is one we just had. Okay, here's one tomorrow from San Francisco. I think it's a bad time for you, like 1 o'clock in the morning, 2 o'clock. He's a neurologist, but he is a neurointerventional, and they're incorporating AI into stroke management. And that's going to be very interesting to see what effect AI he's using to facilitate treatment of stroke, rapid treatment of stroke. Okay, there's that one. And then there's, of course, everyone knows Dr. Goel.
Yeah.
He's a great guy, great teacher. He's taught all over the world. And I've been doing his for almost 8 years. He's a very giving professional, and he loves to teach. Okay, he's giving one on Wednesday also on spine, my book of spine surgery, because that's kind of his specialty, and he's an absolute expert in the C-spine. Okay, let's see what else we have. AI. Here's one. It's for Spanish-speaking people. It's on stroke. That's next Saturday. So, okay, that's it for this week. And anything else anybody has to say? So, okay, guys, have a great day. Thanks for coming. Thanks for making it a
Thank you.
great webcast.
Thank you.